Professor Mike Tipton, thank you very much for joining us today.
It's a pleasure. Nice to be with you, Greg.
Already today, we've had some technical issues, but we actually recorded a podcast back in July that was lost forever due to some podcast demons. So I really appreciate you spending some of your valuable time with us again here today. And I don't want to just recreate the episode that we recorded back then, but I'd like to start on the same note, which is by saying thank you to you, because you might not know this, but I lost my then best friend to drowning when I was 4. And I know a lot of the work that you've done has saved lives, and it's difficult to quantify how many lives it has saved. But I really appreciate the work that you've done, and I'm honored to have you here today.
Well, thank you, Greg. I'm sorry about your friend, obviously, but sadly, it's not an uncommon experience. And people sometimes forget that there's obviously a casualty in these incidents, but there's an awful lot of other people as well who get impacted and affected by these events. So it has been the drowning statistics, which are not great. 1,000 people a day around the world, one person every 30 hours in the UK, a child a week, has been the major driver to what we do.
Let's start with the effects of cold exposure on different parts of the human body. And from reading your work, I know that the thermoneutral temperature of water is about 35 degrees Celsius. And I've also seen and heard you say that we can define cold water as anything below about 15 degrees Celsius. So we'll use that number today. But if we start with cardiovascular health, then it might be helpful to give a relevant context. So let's use the example of a healthy 35-year-old person who spends a total of 3 minutes moving in 12 degrees Celsius water. And I choose 12 degrees for a couple of reasons. One relates to autonomic conflict, which we'll come to later, but another is that that's around the average water temperature around the UK. So if we take this person and assume that on entry into the water, they've jumped in and immersed the head in the water, you termed this initial response that people have to entry into cold water the cold shock response, and have done a lot to unveil its underlying physiology. So before we get to autonomic conflict, I wonder if you could highlight what the cold shock response is.
Yeah, sure. When we started in the last century, about 40 years ago, researching, at the time, the predominant problem associated with cold water was thought to be hypothermia, which had started with the Titanic and had been perpetuated through the Second World War, with people dying hanging onto rafts, etc. But there was a very important report published in 1977 by the Home Office that showed that about 2/3 of those that died within a few feet of safe refuge, and about 2/3 were regarded as good swimmers. And that obviously doesn't point to a protracted period of immersion necessary to become hypothermic. Even in the coldest water and with somebody who's near naked, they won't become hypothermic in less than 30 minutes. So it was clear that something else was claiming these lives in a very short period of time, long before hypothermia could come about. And we'd done some studies in the lab, and I was working at the time with a great friend, excellent scientist called Frank Golden, and we looked at the initial responses to cold water immersion. I remember sitting in an office with him trying to decide what we would call these responses, and we called them cold shock because they were a shocking experience as opposed to a medical definition of shock. Because, as many people who are listening to this podcast will know, when you first go into cold water, you gasp a bit, you hyperventilate, there's an increase in your heart rate, increase in your cardiac output, you shut down your peripheral blood vessels in an attempt to conserve body heat, and that puts up blood pressure. And so that's what we call cold shock. When you see it in its full effect, in full magnitude, that gasp is 2 to 3 litres. It is then followed by uncontrollable hyperventilation that can go on for a minute, and you see a very significant increase in blood pressure. The gasp is, as I say, 2 to 3 litres. The lethal dose of salt water into the lung is 1.5. So you fall into salt water you've lost control of your breathing, you're gasping, and it's luck whether or not you're under the water or a wave is breaking over your face whilst that gasping and hyperventilation are going on. So this is a big cardiorespiratory, cardiovascular response, and it's driven by the sympathetic nervous system. It's part of the fight or flight response. It's just completely inappropriate in water. Not so bad on land when it's preparing you to run away or fight, but in water, particularly where the airway is under threat, it's the leading cause of death on immersion as a precursor to drowning and cardiac problems. So it's not hypothermia, it's cold shock that's killing 60% of those who fall into cold water.
So turning now to autonomic conflict, which is a term that I believe you coined, cold water immersion strongly increases activity in the sympathetic branch of the autonomic nervous system, but submerging the face in water and holding the breath increase activity in the parasympathetic branch of that system. This is known as the diving response. And so there's this unusual situation in which you've concurrently got high activation of both of those branches, producing kind of autonomic conflict, particularly when the breath hold ceases. Can you tell us about how this might affect acute cardiovascular health and maybe lead to some cardiovascular events, including the surprisingly high frequency of arrhythmias that occur even in relatively young, healthy people?
Yeah, sure. Yes, we did name autonomic conflict. In fact, probably my major claim to fame is being able to name things. I should have been a newspaper headline writer rather than a scientist. It's cold shock, autonomic conflict, and all these others. So yeah, you get a cold shock response, which we've discussed. When the face goes in, you've got the ophthalmic division of the trigeminal nerve, and you're stimulating the cardiac vagal motor neurons, which are slowing the heart. So you've got two conflicting inputs, one trying to accelerate the heart, the cold shock sympathetic response, and one trying to slow it, the vagal cardiac motor neurons parasympathetic response, which is why we call it autonomic conflict, because it's a conflict between the two branches of the autonomic nervous system. And if you take somebody and you immerse them into the water to the shoulders, you'll just get a cold shock response driven by cold receptors 0.18 millimeters below the surface of the skin. The dynamic response of those receptors drives directly the respiratory center, causes the gasping and the hyperventilation. That peaks somewhere between a water temperature of 10 and 15 degrees Celsius. If you go below that, the physiological response doesn't get any greater. It just feels colder and colder and then becomes painfully cold. So that's all you're going to see. If you just put the face into a bowl of cold water, which is a classic student practical to demonstrate the diving response, you'll see a bradycardia. It also includes a redistribution of blood flow such that blood pressure stays the same. It doesn't increase as it does in cold shock response. And you'll see an apnea. And it's the response which allows diving mammals to dive for protracted periods. It's an oxygen conserving response. Now, if you go under the water or you dive into the water or you're swimming in the water, then you'll have the opportunity to stimulate both branches of that autonomic nervous system. Now, head-out immersions will normally, in young, fit, healthy individuals, see an arrhythmia in maybe 1 in 100 immersions, and it'll be one-off and of no consequence. If you go under the water or you put the face in the water and you do a protracted breath hold, in that situation, you'll see up to 80% of immersions result in some form of arrhythmia. It may well be just a slowing and an acceleration of the heart, but it might be a supraventricular or a ventricular arrhythmia. And they normally occur within 10 seconds of breaking of the breath hold. So the breath hold is in itself arrhythmogenic. Now, so we've done studies on things like people doing helicopter underwater escape training to fly offshore, which is what they have to do, and seen 25% of them during the period it takes them when the helicopter inverts and then they have to come out and get to the surface. Not very long, 10, 15 seconds. About 25% show an arrhythmia. Normally, that's all you see, and it doesn't descend into anything more critical. But if you have predisposing factors such as long QT syndrome, cardiovascular disease, heart disease, there's an increased chance that that arrhythmogenic stimulus of autonomic conflict will then descend into something more significant. And we've done work with my friend and colleague Mike Shattuck, Professor Mike Shattuck at King's, who's a cellular cardiologist, and shown that you can provoke these arrhythmias in isolated hearts. And the particular arrhythmia that descended into was torsade de pointe. So we think that despite the fact that drowning is a large problem on immersion, obviously in cold water immersion, and does account for the majority of deaths, probably the deaths from cardiac problems are underestimated. And the reason is that this is an electrical disturbance of the heart that may incapacitate you, may cause you then, during agonal gasping, to aspirate water, and it looks very like a post-mortem, like a drowning, because you won't see anything wrong with the heart. It's not like there's been a clot or something obvious that you can see anatomically wrong with the heart. But we've seen enough of these in young, fit, healthy people, these arrhythmias, to know that in people who are less fit or have predisposing comorbidities, that is probably a significant cause of problems on immersion.
And I think I've heard you say that you can reliably induce an arrhythmia in a healthy young person, combining a breath hold with head included cold water immersion, roughly 83% of the time. Is that right?
Yeah, that's right. Yeah, yes, as I say, it goes above 80% in that, and that's young, fit, healthy individuals who've been screened, had a 12 lead ECG to check that they've got a normal heart. Yeah, well, the most recent work, which is yet to be published, but has been done by a colleague and PhD student, Dr. Paddy Morgan, who's an anaesthetist, is we're moving towards actually being able to predict the people who are most likely to show the arrhythmias on whole body immersion just by what happens during a face immersion. So we're moving towards being able to screen individuals who are more likely to have during whole body immersion an arrhythmia. So that's an exciting development, but it's fairly hot off the press and has not yet been peer reviewed or published.
Interesting. And I'll combine two questions in one here. One is, can you mention anything about what the predictive variables are? For example, do you see more pronounced bradycardia in people who are more likely to experience an arrhythmia? And then second, you spoke earlier about how the strong increase in sympathetic activity on cold immersion is inappropriate for us nowadays. Is it a vestige of our ancestors, the fact that we've evolved from simpler organisms in which that type of response might have been adaptive, but nowadays in our human physiology, it's entirely inappropriate?
So, with regard to the predictive nature, the arrhythmias tend to occur when you switch from a bradycardia to a tachycardia. So when you actually look at the ECG of somebody who has been under the water, comes to the surface, takes their first breath in, or starts to rebreathe through their snorkel, you see the ECG shows a period of tachycardia, and then a period of bradycardia, then a period of tachycardia, and this lasts for about a minute, where the heart is switching between this sort of sympathetic driven rhythm and a parasympathetic driven rhythm. And where we see the change in that rhythm is where we're most likely going to see the ventricular, supraventricular arrhythmias. So you've got a dysrhythmia going on anyway, a sort of wave of tachycardia followed by a wave of bradycardia. And that presumably is just, the two inputs into the heart taking control one after the other. But where those rhythms switch is where you're most likely to see an ectopic, an arrhythmia. So that's if you see somebody who's got that big variation in bradycardia, tachycardia post breath holding, then they're the people who are most likely to show some kind of arrhythmia. So that's one way of looking at it. Your other question was about the existence of the sympathetic drive. The sympathetic drive to a threat is normal, but it's normal for air. So, if and ancestrally, you're quite right. If we came into a situation where we had the option to run away or fight, it's the sympathetic system that is the system that will prepare you to do that. And it does that by increasing breathing, increasing blood flow to the muscles, increasing cardiac output. So you're primed to go, and releasing the stress hormones as well. And that's great, and very useful if you're about to engage in a 100-meter sprint or something like that, or a boxing match. However, if you're in a situation where you are periodically being submerged by waves breaking over your face, or you've fallen from a height and you've gone under the water, that response is of no use whatsoever. It's just a good response in a bad situation. So it's little or no use. In fact, it's probably hazardous, particularly when compounded by the drive from the afferents of the cold receptors. But it's an absolutely normal and natural response. And one of the one of the questions that we spent a bit of time thinking about was, why do 80% of the deaths that occur in triathlons occur during the swim phase? And all of those people, and this is up to and including Ironman, so these people are not untrained. They're young, fit, healthy individuals, or they're old, fit, healthy individuals. And they've done lots of training, and they've not had these problems during training. So what's different about a race that increases the likelihood of a cardiac problem? And most of these deaths are cardiac, incidentally. And it's probably in part the sympathetic overdrive that comes from the fact that you're in an event. And anyone of your listeners that's been involved in the mass start in a triathlon will know that it's a fairly aggravating and exciting experience. The first 400 meters, which is where most of these deaths occur, just involves pulling on neoprene and shouting at people. But the other thing that happens is when you turn to breathe, because there's so many people accumulated together at the start, on the mass start, sometimes you can't take a breath because you've got a plume of water over your face, so you end up extending your breath hold time. Now, that sympathetic overdrive, that face immersion, that extended breath hold, is exactly the combination of factors you need to induce autonomic conflict. And so, whilst this at one level is of tremendous academic interest, they also have some practice. I mean, that's the nice thing about what we do. It has, we're applied scientists, so we take an understanding of the mechanistic physiology and try to apply it. And you say, okay, well, if I'm running a mass participation swimming event, I'm going to make sure we have waves where people are separated, where they don't end up clambering over each other, don't end up having to extend their breath hold. We're going to swim them a certain distance before we turn them, so we don't have coming together at buoys and things like that. So yeah, there we are. I mean, it's an interesting combination.
So staggered starts and appropriate course planning can make a difference.
Oh, absolutely. And as I say, and also, as best you can, watching out for people who have channelopathies, atherosclerosis, myocardial hypertrophy, ischemic heart disease, long QT syndrome, or acquired long QT syndrome from the drugs they're taking. Some drugs, antihistamines, for example, can extend the QT interval and make it more likely that the arrhythmias you get from autonomic conflict will descend into something more serious. They're the predisposing factors.
Which is interesting in the light of the fact that a lot of those triathlons probably take place during the summer, a time of year when people are more likely to take antihistamines to manage hay fever. But Mike, I know you've done some work looking at. Oh, sorry, there's a bit of a delay. I apologise.
No, I was just going to say, and even though it's the summer, in many parts of the world, the summer still will have water temperatures that are cold enough to evoke cold shock, which we see in terms of an increase in respiration at water temperatures around 25. I mean, it's easily suppressed then. When you go into a swimming pool, you might have a little like this, but it's easily suppressed. As the water temperature falls, it gets a much more powerful response. But of course, even if you're in water and wearing a wetsuit, the sympathetic drive from cold shock is then often replaced by the sympathetic drive from the fact that you're at the start of a competition.
Yeah, absolutely. And I know you've done some work showing that cold acclimation can quite quickly and reliably reduce the cold shock response. Can you give an example of what type of protocol would do that?
Yeah, sure. So, because the cold shock response is evoked by the dynamic response of the cold receptors, and it peaks in the first 30 seconds and is pretty much disappeared after 3 minutes, you only need to do repeated short immersions in order to repeatedly evoke that response and develop. It's a true habituation. It's a decreased response to a constant stimulus. So our standard protocol would be something like 6 3-minute immersions in cold water, head out immersions. And over those 6 immersions, you'll see roughly a halving of the respiratory and cardiac response to immersion. What normally happens is the second immersion is the worst for people, and it's just one of the functions of cold water in that it's really hard to give people informed consent about water temperature because they immediately translate it into air temperature. So if I say to you, okay, we're going to do 6 3-minute immersions, are you happy to do them? And you say, well, what's the water temperature? And I say, oh, it's 12 degrees. You think, oh, it's 12 degrees outside. That's not too bad. But of course, 12-degree water is a completely different physical challenge in terms of the physics of the water, the conductivity and specific heat to air. So normally the first one of these immersions, despite our best intentions to inform people, is something of a surprise. And the second one they get more anxious about. And then after that, you start to see a decline in these responses. And that decline after 6 immersions, as I say, is about a 50% reduction in the cold shock response. Importantly, your breathing gets back under control sooner. So it's not just a matter of the ventilatory response. It's actually how quickly you can suppress that respiratory drive, and that occurs more quickly. And then we've done tests where we've looked at people 14 months later, and they still have a 25% reduction in the cold shock response. So it's a fairly permanent alteration, a combination of psychology and physiology, I suspect. And we know that that adaptation occurs somewhere more central than the peripheral cold receptors, because if you repeatedly immerse one side of the body to get a cold shock habituation, if you then turn the body over and immerse the other side, you see the same reduction. That's even though you're exposing the side of the body that's never been in the cold. So this is occurring more central than the peripheral cold receptors.
And if people were interested in cold adaptation, then what would be an appropriate density of those sessions? Would it be spacing 6 sessions out over 3 weeks, for example?
Yeah, it's a good question to which we don't really know the answer, but we've actually done it for demonstration purposes in the course of a day.
Oh, wow.
So we've actually had people do 6 cold water immersions. They're only 3-minute immersions, so they start at 9 o'clock in the morning and then do one every hour. And straight after the immersion, they have a shower. And because you've only cooled in 3 minutes, as I said earlier, you've not really got any core cooling going on. It's just the superficial skin and tissues that cool. So you can very quickly warm them up with a shower and then rest for an hour and do the same. And we've seen that protocol work over the course of a day, going through exactly the same kind of process as you would see if you did it one a day. So how long you can leave between successive immersions, whether you could leave it and do one a week, I suspect the time course of the adaptation would be slower then. But the study hasn't really been done.
Obviously, metabolic health and chronic inflammation are very relevant to cardiovascular health too. And there's some interesting science showing that cold exposure can affect metabolic health and inflammation. So what are some of the potential upsides of cold water immersion on cardiovascular and metabolic health?
Yeah, I mean, the preamble to this, which I'll keep brief, is that for years we've looked at the hazardous responses to cold water immersion, because of the great toll in terms of lives lost and lives changed that's resulted in. However, in the background, there's always been this philosophy of going into the water for health and taking to the waters. I mean, Hippocrates did it, Thomas Jefferson, Darwin, Florence Nightingale. I mean, the Victorians did it. I mean, lots of seaside towns in the UK, Brighton, Penzance, places like that, exist because of people wanting to go to take to the waters. And so there's always been this background of a health benefit of going into seawater, um, which of course is going to be cold around the UK anyway. This took off during the pandemic, where lots of people started doing open water swimming and cold dipping and cold swimming, and it's now become something of a vogue. It's hard to find somebody who's not doing cold water swimming at the moment. And the claims that are made for that are normally threefold. One, it's alerting, it wakes me up, it sets me up for the day. Two, I haven't had an upper respiratory tract infection since I took up open water swimming. And three, some of the conditions that people have, both psychological and physical, seem to improve, or there are claims that they improve, and that may well be an anti-inflammatory component. There is a metabolic stimulus that comes from going into cold water, because of course those cold receptors that are driving the cardiorespiratory system are also starting to activate the metabolic system to induce pre-shivering tone and shivering tone to defend deep body temperature. And there are papers that talk about alteration in adiposity and changes in brown fat activation. Although, I mean, in our world, where we're talking about survival and large amounts of heat production necessary, brown fat is a negligible contributor to that. Now the alerting bit, let's just quickly go through those. The alerting bit is obvious because it's the cold shock response, it's the release of the stress hormones, it's that fight or flight response. So it's unsurprising that if you take a tropical animal who wants to be naked in 28-degree air and drop it into naked into 12-degree water, you're going to get a response that's alerting. So we understand that. We understand the mechanisms and the pathways associated with that, and we understand the hormones that are released in order to produce those responses. The immune function, I think the jury's still out on that. I mean, one thing to say about this is that this side of the double-edged sword of cold water immersion is much less researched than the other side. I mean, we can talk for hours about the hazardous responses to cold and their pathways and mechanisms and consequences. Most of the evidence for the beneficial side is anecdotal. Although, as I say to people, anecdotal evidence is still evidence, although it's the weakest form of evidence. So people, this upper respiratory tract infection, we've seen in work we've done that there's a reduction in people who do open water swimming, but there's an equal reduction in people who do indoor swimming. So I think there's still some query about that. And I think it's because what nobody has ever established, or as yet, is what's the dose of cold. And we know that a very brief cold water immersion is likely to activate the immune system. But if you stay in too long and you start to cool, it's actually likely to disable the immune system. So I think some of the contradictory findings in the literature are partly due to what's being measured, whether some of the blood-borne markers of immune function are being measured, or whether it's actually something like upper respiratory tract infections reported. And also because people are doing different protocols. My personal view is that if there's a benefit to cold water immersion, it's probably accrued in the first couple of minutes. It's associated with the cold shock response and the release of and the neural stimulation and the release of the hormones associated with that, just couple of minute immersions. And then the longer you stay in cold water after that, the more likely you are to have a problem of either in the acute or chronic phase. The anti-inflammatory thing is can be to do with things like face immersion, which we've already discussed that in some situations is particularly hazardous. But we know that you get a powerful parasympathetic stimulation from immersing the face, and we know that the vagus nerve has been shown to have significant anti-inflammatory effects. In fact, vagus nerve stimulation is used to treat drug-resistant epilepsy and depression in some parts of the world. We've actually done studies with an individual who had pretty profound depression, and with repeated immersions in cold water, she became depression and drug-free. So I think the summary of it is that there are three main prongs of claim. We have a hypothesis for each of those, but only really the cold shock and the alerting and awakening side is fully understood. For the people that this benefits, the thousands of people now. I mean, our local club here in Perranporth went from 25 to 1,000 members. For the people who benefit from it, that's sufficient. But as a scientist, and what I want to know and what our group wants to know is what's going on, and can we produce that with a much less hazardous stimulus? Could you just put a hand and a foot? Could you do a cold pressor test? Because there is no doubt that although there are beneficial effects, there are also potentially hazardous effects, and we're seeing an increase in the number of deaths on immersion. We're seeing an increase in the number of rescues required for people who go open water swimming, and my inbox is regularly added to by people who've had problems, so we want people to do what they want to do, and if what they want to do is open water swimming, great, but it's our job to understand what's going on and also to make it as safe an activity as possible.
I worry that a lot of the narrative that's shared by scientist influencers and physician influencers has been a bit imbalanced, and that's been exacerbated by some TV personalities. And you spoke about rigorous experimentation. I think a lot of the issues that we face stem from the fact that we don't have well-controlled experiments. And in these types of observational studies, we can't really determine that it is the cold exposure that's leading to these benefits. And when you think about open water swimming, there are many different beneficial stimuli at play. There's the social component, there's the physical activity, there's the fact that they're taking place in natural environments, there's the sun exposure. All of these different things can independently have positive effects on somebody's health. But what you're saying is that there are potentially some upsides that are relevant both to cardiometabolic and brain health. And those include things like the fact that this is going to increase glucose uptake into muscles if they are more active as a result of shivering thermogenesis, for example. There's a lot of talk nowadays about adipocyte browning and brown adipose tissue thermogenesis. And interestingly, there seems to be some evidence suggesting that even sleeping in a cool room might increase brown adipose tissue thermogenesis and yield some positive effects on insulin sensitivity, for example, in people with poor blood sugar control. But then turning to the brain, so many people are now advocating cold immersion at the start of a working day, and they focus on some of the mechanisms that are at play. You get this strong increase in noradrenaline in the brain, and that's having some acute effects on alertness and possibly some other positive effects on simple cognitive functions like reaction time. But I'm curious about what your thoughts are on the likely effects on more complex cognitive functions, bearing in mind that lots of people who are doing this are using it for knowledge work, and they need faculties like working memory, executive functions. And my impression, having looked at some of the research on cold exposure, not through water, but just through cold ambient conditions, is that these tend to be hampered rather than improved by cold exposure.
Yeah, I mean, I think probably the easiest general comment to make on that is we're back to the issue of dose of cold. If you have a short period of cold exposure that's, I'm talking seconds, not even minutes, that's sufficient to release the stress hormones, you're likely to improve, things like attention, vigilance, some of the simple more simpler responses. If you've spent a longer period in cold, then I think you'll start to move down the path of that being degraded. And often it's one of the problems with these types of studies, of course, is the way you're measuring things like reaction time or complex reaction time. That in itself is impacted by the fact you've got peripheral cooling. So, the whole thing gets very complicated. When people get in touch with me, if they say I want to take up cold water immersion for weight loss, let's say, or metabolic health, I'll often say, well, you're much better off going for a walk, because you're now, you're now weight bearing, and you're going to get a lot more bang for your buck with a half an hour walk than you are with a half an hour float. If you want to, so it depends what you're trying to do. I mean, and I agree entirely. What we don't know is when somebody goes and does, we haven't really identified the active ingredient in open water swimming. Whether it's meeting friends, the green, the blue therapy, the being weightless, the doing some exercise, or the getting cold, or the having the cake and a hot chocolate afterwards. And so all of these things, until the studies are done, which I'm not sure they're going to get done because it's really hard to get funding for that type of study. Much easier to get funding for sudden cardiac death on immersion and drowning and hypothermia. But until those trials are done where you've isolated cold, we're never really going to know. And in the meantime, as I say, I mean, anecdotal evidence is still evidence, that's fine. And a placebo effect is still an effect, but it doesn't really advance us anywhere in terms of what's going on. We know about vagal stimulation, we know about anti-inflammatory cytokine initiation, we know about serotonin release. We've got lots of hypotheses, but which would affect, physical and mental well-being. But as yet, that's not been teased out at all. Nearly all of the studies are descriptive. They go, people who are doing open water swimming are asked whether they think it's good for them. I would suggest that they would be really strange individuals if they said no.
And your comment about manual dexterity was interesting because some of these cognitive tests rely on people pressing something in response to some sort of stimulus. And if they've got peripheral cooling of their muscles and their nerves, then they're not going to be able to move their hands as well. So it's one of those experimental variables that you need to actually consider as a scientist. And it's probably only people like you that would be aware of those, Mike. But that brings up the subject of non-freezing cold injury in a very roundabout way. And I mention this just because it's probably not something that's on the radars of many people. Can you just explain what non-freezing cold injury is? Because hypothermia gets so much airtime, but my impression is this might be more burdensome.
Yeah, you're right, Greg, that when people talk about the positive, negative effects of doing cold water swimming, dipping, ice, the ice mile, they'll talk about, they'll worry about the heart, they'll worry about aneurysms and hypertension, and they'll worry about potentially, drowning. What you really rarely see in the literature is, well, what about damage to my peripheral vasculature? And what most of your listeners will have heard of is frostbite, because that's, well known and understood, and the gory pictures of mountaineers losing, bits of their extremities because of frostbite. But there is another condition that is equally debilitating, although much less well known, which is non-freezing cold injury. And as the name suggests, it's an injury to particularly the extremities. Again, it's the same areas as you would suffer from frostbite, but there's no freezing of the tissue goes on. It's just a damage to the microvasculature and neurovasculature tissues as a result of prolonged exposure to cool conditions. So historically, you may have heard of terms such as paddy foot, trench foot, these kind of conditions. And, I suspect that, this is on a continuum. I suspect anybody who's, grown up outdoors, ridden a motorbike, played field sports, done any mountaineering, will have a degree of peripheral neurovascular damage, microneurovascular damage. But it doesn't really impact them. They might just find that their feet are cold, get cold really easily, stay cold a long while, and are hard to rewarm. But that can progress to permanent pain, sweating in the damaged area, and cold sensitivity. And, at worst, it's life-changing, may involve amputation in the fullness of time. And again, it's a condition that you rarely hear spoken about, full stop. And you certainly rarely hear it spoken about in individuals who are trying to spend longer and longer in colder and colder water. The problem with it is we don't really know very much about non-freezing cold injury. It's never really got to the top of the pile to get the funding to look into the pathogenesis and the pathology. And also, we're not even sure whether it's primarily a vascular injury or a neural injury, or whether it's vascular causing neural or neural causing vasculature. But we do know it's a problem, and we do know it's a lifelong problem. When I was at the Institute of Naval Medicine, there were people still being tested for non-freezing cold injury in the 80s and 90s who had picked up their injury in the 50s. So it's certainly something that people need to be made more aware about. And the good news is that we're actually about to launch a website. My colleague, Dr. Claire Eglin, sorry, she was Frank's, is about to launch a website on the Portsmouth University website, which will give you lots of information about non-freezing cold injury and answer the frequently asked questions.
We could spend a lot more time speaking about exercise specifically, but I'll just point out a couple of things that I've learned or had drilled home while familiarizing myself with your work, Mike. One of them is that some people will use pre-cooling before exercise in the heat to improve performance, and that's often done by way of something like an ice vest. But that's not necessarily optimal, in part because cold exposure can acutely lead to diuresis. And so given that fluid balance is so important to exercise in the heat, the net effect might not necessarily be positive. And if pre-cooling is used, then arguably people should pay attention to their hydration. And then secondarily, lots of people use cold exposure post-exercise. Historically, this has often been done to reduce inflammation and associated delayed onset muscle soreness, DOMS, but there's some evidence suggesting that that could actually hinder some training adaptations in the same way that other forms of reducing inflammation, such as taking anti-inflammatory nutraceuticals, including high-dose antioxidant vitamins, can hamper some of those adaptations. But I'd love to move on to some ways by which we can progress cold exposure and think about a spectrum of different types of interventions according to how intensive they are. And I was thinking about this before recording today, and it struck me that maybe the lowest end of the spectrum that one could consider would be to actually use something like menthol application or ingestion, because that seems to stimulate some of the same receptors that are involved in initiating responses to cold, specifically the TRPM8 receptors. So I was curious about whether you thought at all about whether that might be a gateway to cold adaptation, or whether that would just be an insufficient stimulus to initiate the response.
Yeah, it's a good question. It's one we asked a few years ago with a PhD done in our lab by Jason Gillis. And we did some work also with Phil Newton and Martin Barwood. And we were looking at, in those days, the original question came from a product that was a vest that was soaked in menthol and ethanol. And it was a cooling vest that was supposed to, the ethanol was supposed to increase evaporative cooling because ethanol evaporates more easily. And the menthol was supposed to stimulate cold receptors, which is, as you've mentioned, and which is why it's included in lots of products that claim to make you feel fresh, because it's actually cold receptors that are being stimulated. And we did look at it. People can look up the papers themselves, but we looked at the impact of the application of menthol. And interestingly, although it made you feel cooler, the other thing it did, it activated the heat conservation pathways. So it might make you feel cooler, but actually you start to defend that temperature. So overall, it's not making any difference to your deep body temperature because you've just vasoconstricted a bit. The other interesting thing is repeated application induces an habituation. So actually you habituate to repeated menthol application in the same way as you would habituate to repeated cold. But the most important point is the last one you made, which is that it really is a pretty minimal stimulation in comparison with cold water. So nobody, to my knowledge, has done the study of repeat menthol application and then looked at whether that changes your response to immersion. But my guess is it wouldn't.
Next up the spectrum might be something like a cold pressor test, something like exposing the hands or the feet to cold water. They have certain characteristics that mean that we're able to gain or lose heat through them very efficiently. They've got a large surface area to mass ratio. They're dense with arteriovenous anastomoses. So what about just plunging your hands or your feet into cold water for a few minutes as a better gateway than using menthol?
Yeah, well, it's certainly a more significant stress. Anyone who's done a cold pressor test will know it's fairly tough in that you're putting a hand or a hand and a foot into water that's freezing cold, and you will see an increase in heart rate. You don't see the gasping, uncontrollable hyperventilation and increased blood pressure to the levels you'd see with whole body immersion. But it's certainly a step in the right direction in terms of you wanting to up the cold stimulus. What we don't know, and it's part of the reason why we want to go beyond the anecdotal evidence of the open water swimming, is whether it's sufficient to induce any of the well-being effects, whether it's physical and mental, that we see with whole body immersion. So, the $64,000 question is, what's the minimum surface area you need to stimulate with cold in order to get the beneficial effects? Now, there's some indication by going from whole body immersion to showering, for example, that showering can produce some of these beneficial effects. But we know that showering is not the same level of stimulation. That may be the next level of stimulation that you're coming on to. But it's we don't know the answer. We don't know the answer to that question. But you're definitely activating the pathways, although not to the degree that you would see with a whole body immersion. You rarely see a big respiratory response to a cold pressor test. Mostly the response is cardiovascular.
It was indeed showering. Very prescient of you, Mike. And I was going to also ask about how somebody might progress the showers in terms of the surface area that's exposed to the cold water and or the temperature and or the duration. I know that you've done some work looking at showers as part of a cold adaptation protocol.
Yeah, so showering is about 40% of the body surface area compared to whole body head out immersion, which is nigh on about 90%. So the showering is not so effective, but it does evoke a response, and you can habituate to that response by repeated showers. You can increase the surface area. There's ways of going about it to make it more comfortable. You can start with a warm shower and go cold. That doesn't give you the same stimulus as if you go straight into cold, because the rate of change of skin temperature, which is the driver for the cold shock response, is less. You can start with your back to the shower, and once that you've done 30 seconds of that, you can turn to face the shower, just with the warning that as soon as you start putting your face under the cold water and associated with holding your breath, you're increasing your likelihood of cardiac arrhythmia. So if you're going to do back and front, do back and chest, not back and face. And we've demonstrated that you can see an habituation. It's not as great an habituation as you see with repeated cold water immersions, but you do see some habituation on immersion having had cold showers. But it's then as we're discussing, it's a level down from whole body immersion.
I'm glad that you mentioned preheating, because I see a lot of people advocating the contrast method, where they might, for example, use the sauna before cold showers and alternate back and forth between them. But if we think about the next level, that might be bathing in a body of cold water, which I suppose could start with staying relatively still and then moving the limbs so that there isn't that boundary layer that's been heated and there's a stronger thermal stress. Might that make sense? And could you go from there to immersing the face in the water as well to add on the intensity stimulus?
Yeah, I think so. I mean, the static immersions are fine. I mean, I happen to believe that the benefits of that people are claiming for cold water immersion probably come from just sudden cooling of the skin on initial immersion. I think the exercise, if anything, confuses the picture, because now you don't know whether it's the exercise or the cold. But I suspect the exercise is not necessary. The problem with putting your face in, which I think is important at one level in terms of, we've talked about the vagal response, and we've talked about that having significant anti-inflammatory responses. I think that's okay, provided, again, you're conscious of the fact that that face immersion doesn't want to be as part of a protracted breath hold, because of the increased danger of cardiac arrhythmias on breaking that breath hold. So yeah, I think that you've got to the point where you probably don't need the exercise. The exercise will be good for you, but if you're trying to tease out whether it's the cold or the exercise, and if you're going into freezing cold water to exercise, as I said before, you're much better off just exercising in air, because you'll consume more calories and you'll, challenge yourself much more by walking along the cliff than you will by swimming in the sea. There are, other benefits to be gained. Yeah, I mean, I think that's probably a reasonable discussion of the different levels of cold exposure.
And regarding the contrast method, do you think that alternating back and forth between the sauna and cold immersion could adapt somebody to both heat exposure and cold exposure at the same time? Or might this be a bit like concurrent exercise training, where what we see is that were you to do endurance exercise straight after resistance training, then you might well blunt the adaptations to the resistance training?
Yeah, very little been done, and that which has suggests that there are components of both that can be adapted. So you should be able to adapt the cold shock response, even if you've gone into I mean, this is classic Scandinavian, out of the sauna into the cold. There's evidence that the cold shock response is diminished by preheating, because there's so much heat stored in the tissue that the heat moving out from the body slows the rate of change of skin of the cold receptors. So there's an attenuation of the cold shock response, even though the skin temperature doesn't, shows a very similar profile. So I think, yeah, I mean, the limited evidence there is, and that's going right back into the 50s and 60s, suggests that you can get some concurrent adaptation, but it's not as comprehensive as you get with a full-on heat acclimatization program or full-on cold acclimatization program. I guess, I mean, the interesting thing about all of this is, and maybe it's something we're going to come on to, but it's why these things are having a beneficial effect. Why are we getting people claiming that cold immersion is good for them and that it's changed their life and they're mentally, they're both psychologically and physically better. I think it's probably because of where we've got to as a species.
I was going to say, what comes to mind is a combination of mindset effects, where people are expecting beneficial effects of engaging in things like sea swimming, and then also the fact that, as you say, Mike, people nowadays are relatively thermostatic, and we need to challenge different organ systems in our bodies if we want to retain their functions over time, especially as we get older. I'd just like to ask a couple more questions about timing, starting with thinking about the seasons. Obviously, in the UK, for example, there are large fluctuations in ambient conditions from winter to summer. Do you think that it will make sense to focus more on heat exposure for somebody during the cold months of winter, because they're going to get some cold exposure incidentally, and then cold exposure during the warm months of summer. So they're challenging both ends of their thermoregulatory capacity.
Yeah, I mean, it's something that's not been tested. I mean, just, but it follows on from, excuse me, it follows on from what you mentioned about. I mean, I used the term thermostatic in the editorial I wrote about, humans being too thermostatic. That what we used to do naturally, which was get cold and get hot during the course of pretty much every day, we now don't do at all. And it's interesting that, I mean, not just in the sort of well-being area, but also in the clinical area, we're seeing lots of work now being published, and we've done some of it. One of my colleagues, Dr. Ant Shepherd, is working in this area with Tom James, looking at the benefit of heat exposures for glucose sensitivity, type 2 diabetes. We've talked about cold. So I mean, I don't know that there is any evidence to support your your postulation, but it seems to make common sense. It seems to be common sense that if we're in a situation where now we don't get any variations or very minimal variations, that we have to artificially introduce those. And in the winter that would be heat, and in the summer that might be cold. Because we're now having to artificially introduce things that at one time happened naturally, including driving to the gym to go and do some exercise, which is part of that overall picture of a species that has evolved technologically rather than physiologically. And as such, in order to perturb the systems we need to maintain functionality, we have to artificially go and run on a treadmill, or maybe artificially go to a sauna, or artificially go to have a swim in the cold water.
Don't be that person that drives to the gym to walk on the treadmill. Nobody likes that person. And then regarding time of day, if you look at the incidence of cardiovascular events such as heart attacks, then they tend to cluster in the morning, especially between about 6 a.m. and 12 p.m. We know that there are large circadian fluctuations in various different functions within the cardiovascular system. There was a really nice paper published recently by David Bechtold and his colleagues looking at circadian rhythms within the sinoatrial and atrioventricular nodes, which seem to be driven by rhythms in the heart and brain. And those might underlie that time of day variation susceptibility to these events. So I was just curious about what your thoughts are on the best timing within the biological day for cold water immersion, because so many people advocate doing it in the morning, sometimes in the face of sleep loss and circadian misalignment after waking to an alarm clock in the morning before work, so that it improves their cognitive function, which to me seems completely misguided.
So, in that introduction, you probably introduced enough conversation for another hour. So where do we start with that? I've always been fascinated by circadian rhythm. If you allow people free run, i.e. you put them in an aperiodic environment, we tend to run on about a 25-hour clock. Once you get free running, you're much more susceptible to cooling and heating. You don't defend the deep body temperature enough. So these are really interesting areas that that perhaps, I mean, you can reintroduce that periodicity by giving people food at certain times, so you don't have to have a light dark cycle. But it does become interesting when people get in a situation where they're in a constant illuminated environment, or they're in a polar region which is dark, etc., etc. The other thing, again, it comes back to this thing about which you touched on with the ice vest. We're an integrated animal, and what we do to ourselves will have a whole range of impacts. And sometimes we ignore some of the why, because because of the way we're educated and the way we have expertise, we're all siloed. So the ice vest, yes, you're absolutely right, will cool the tissue, which might initially look good, but at the same time, it's causing a cold diuresis. The other thing people forget is that when you get up in the morning, you're doing exactly that. You've just done a period of bed rest. And when you're laying horizontal, your fluid dynamics change. You start, you're now in essentially you've done a 6 or 8 or 10 hour bed rest study where you will have reduced the amount of circulating blood volume you've got. because you've gone into a horizontal position as opposed to an upright position. And now you go straight to an upright position. You go into a bathroom and you splash cold water on your face as part of getting up in the morning. Well, as a thermal physiologist, I've got several alarm bells ringing. And so it doesn't surprise me that we see that peak in cardiac problem around about that time, when somebody's risen from being horizontal for 8 hours, has gone into a bathroom and has splashed a load of cold water on their face whilst breath holding while they do it. Now, when should you do, therefore, your cold water? Well, you can, again, you've got to be very careful that we're not being a bit like nanny statish and we're like the fun police.
Yeah.
But it does bother me that people don't have anything like the amount of information they need to make smart decisions. I don't want them not to go for their morning dip or go to do their whatever that they want to do, but I just want them to be availed of as much information to do that safely. This is one of the reasons why we published the paper on cold water therapies, a recent paper in the British Journal of Sports Medicine, about how to do them by minimizing risk, and also try to publicize things like non-freezing cold injury. So for me, I would be doing my cold water dip at the time when it's least likely to have a detrimental or negative effect on me. And I think I'd probably want to make sure that I'd been up and about for a couple of hours before I went and threw myself into cold water. But I have no evidence particularly for that, and because I think actually the problem we see early in the morning with cardiac problems is that combination of getting up and getting a wet face. So it comes back to the. So in the paper I've just discussed, we give advice for people who want to take up cold therapies. We give advice for groups that want to provide the experience, and we give the advice to doctors to screen people. Even then, with a proper, everyone should make sure they're fit and healthy enough to do this thing, and should have a proper medical. Even then, people need to realize that that medical can't pick up all of the potential conditions that could end up with a catastrophic outcome when you go into cold water. The most recent case I've been involved in has been a brain hemorrhage for a 39-year-old young, fit, healthy guy who went and did a cold water exposure, and 1 minute after leaving, the water collapsed with a ruptured aneurysm. So that's going to be really difficult to pick up at a reasonable medical. So this is not without risk. So by all means, do what you want to do, but try and avail yourself of the information. And even if it's not a catastrophic risk like a burst aneurysm, it might be something like peripheral vascular damage that you'll notice more in later life. But once you've got all the information at your disposal and you've become educated in that way, then it's up to you to make a decision. As part of that, and it's something which is a more modern phenomenon, is when I was starting, if you wanted to get information on something, you went to a library, you went through Index Medicus, and you got the peer-reviewed paper and you read it. Now I can go online and I can just type in cold water therapies. I can get a whole host of people who have no qualifications, have very little understanding. They might have done 2 or 3 immersions, swims themselves, and are now setting themselves up as an expert in the field. Just be aware generally about where you get your information from, and ask questions like how many years have you studied this? How many publications do you have in this area? Because I do worry that we've got people screaming into cameras, "Go! Anyone can do this." And as I say, and at the same time, we've got the death rate increasing and we've got the rescue rate increasing.
I was interacting with a chatbot recently that was based on a large language model that had pulled data from a popular podcast. And just out of curiosity, I asked it a few questions about the potential risks of cold water immersion, and it couldn't give me a coherent answer. So I think the work that you're doing in science communication is so important. and you've done some terrific work in everything from the popular media to podcasts like this. So keep up that good work. And sure enough, the next question that I was going to ask you is about that BJSM paper, and just whether you could just finish with a few quick pieces of advice for people who want to try and stay safe during the cold water immersion that they engage in, because they do really enjoy that particular activity. And maybe also within that, could you just mention a couple of absolute contraindications or relative contraindications to that type of activity?
Contraindications, which should be picked up by a medical screen. Remember, a tropical animal going to cold water is probably the most severe stress you can place on the body. And you wouldn't go out, buy a pair of running shoes and go straight into a marathon. You know, you would make sure that you were fit enough and had done the training and did it incrementally and got to the point where you could do that. So anybody with a family history of sudden or unexplained cardiac death, hypertension, like blood pressure, cardiac dysrhythmias, people ischemic heart disease, long QT syndrome we've mentioned, peripheral vascular disorders, history of seizures, history of family history of aneurysms, any other comorbidities, people who are on various drugs for conditions. All of these are red flags for going and putting yourself into a situation where you're going to put a significant strain on the cardiovascular system and the respiratory system. But particularly for the health side of things, it's going to be the cardiovascular system. If you've got the all clear and you wanted to go about it in an incremental fashion. So you've got your medical checkup, you've avoided concurrent stresses and medications. Make sure you swim with a group, preferably on a lifeguarded beach, but with people who know what they're doing. I do a lot of work with the Blue Tits, excellent group who are trying to get people to do open water swimming that want to do it, but in a very safe way. There's lots of advice on their website about doing things safely. Make sure you know weather forecast, you analyze the swimming location, follow an incremental approach. It's not an embarrassment to wear a wetsuit. Wear a wetsuit if you want. We know from studies that we've done that you'll get just as much benefit from wearing a wetsuit as you will without, in terms of that first couple of minutes. Habituate to the cold. We've talked about how you might do that, but do that. Don't do that on your own. Again, do that in a supervised way. Wear a visible hat, a tow float. You've got to enter the water slowly. The cold shock response is both temporal and spatial summation, so the slower you go in, the smaller the response. Get your breathing under control before you start swimming. Swim parallel to the shore so that if you become incapacitated in any way, you can just stand up. You've not found yourself 200 meters offshore. People have made that mistake. Avoid prolonged breath holds associated particularly with face immersion. Limit your exposure to 10 minutes. I see absolutely no reason for the vast majority of people to stay in for more than 5 or 10 minutes. The benefit, I believe, has been accrued by then, if they're, of the speculative benefits and hypothesized benefits. Definitely don't rely on how you feel. With cold habituation, you essentially disable your behavioral or perceptual thermoregulatory system. So you've got people who, when they're cold habituated, can swim to the point of unconsciousness. That happened to probably the most famous open water swimmer of his generation, Jason Zerganos, studied by Griff Pugh, who, when trying to swim from Ireland to Scotland and the North Channel, died about a mile or two from the Scottish coast, having cooled to the point of ventricular fibrillation without actually ever feeling cold. So don't rely on how you feel, rely on time, 5 to 10 minutes max. If you get in trouble, turn over, float on your back. If you go into the water and you're suffering cold shock, float on your back. That all comes from our research on the cold shock response, and that's been taken up by the RNLI. We work very closely with the RNLI on the Float to Live campaign. You can just Google that and find out more about that. And just remember that when you leave the water, even if it's just 5 or 10 minutes, you need to warm up properly and make sure that you've got some blood flow back to the extremities before you start we talked about manual dexterity and manual function. What happens in a lot of times is people come out of the water and they jump in their car and they start driving. And what bothers me, they're probably driving at the time where they're most physically disabled that they've been all day. Depending on how long they've been in the water, it might be just a peripheral disability, but it might also be that they've got some central cooling, so some of their complex decision making is impaired. I haven't done a study to look at the number of car accidents driving back from open water swimming, but there's an interesting question to be asked there. We're doing the study looking at the impact on driving performance using a driving simulator at the moment, but that's not yet been published. And you can see all of that in the British Journal of Sports Medicine paper.
And I will link to that paper and several other papers that you've mentioned as well. So I'll just end by saying thank you so much for your time today. And I think the work that you do is going to be increasingly important as time goes on too, as the climate becomes more extreme. Because I know that we focused on cold water immersion today, but you're interested in extreme environmental physiology in general. So keep up the great work. And I realise we've gone 10 minutes over, so you've been very generous. And I really look forward to what comes out of your lab in the near future.
Lovely. Okay, well, it's been lovely to talk to you, Greg, and thanks for the invitation.